So it will be taken by Dr. Sunil. So we can have sir's presentation. We can have it for around 45 minutes, followed by a discussion round. So we are having Dr. Sunil to take the class for us. Dr. Sunil is the additional director with Trivandrum Institute of Palliative Science and Oregon of Pallium, India. He is having an experience of more than 15 years in palliative care. I welcome you, sir.
Thank you, Rajlakshmi, and I welcome you all. So this ECHO was made possible in joint collaboration between Pallium India as well as PalliCovid Kerala. PalliCovid is a group of like-minded doctors who are somehow related to palliative care. So they have made an ebook for how to tackle the sufferings in COVID-19. So I am also one of the members. So let's go to the common symptoms which is seen in COVID-19. So fever is the most common symptom which occurs in almost all patients, 83 to 99%, followed by cough, fatigue, anorexia, breathlessness, sputum production, and myalgia. So first we will concentrate on respiratory symptoms, so which includes breathlessness, cough, and secretions. So many of these slides are made by PalliCovid members. So breathlessness, as we know, breathlessness is a subjective experience, and and those who have had breathlessness, they can understand what was the experience. But at the time of COVID, this will be more because we are hearing more information regarding breathlessness, and people are put on ventilator, all those things. So there will be a lot of anxiety which can actually increase the breathlessness. And all of you know that breathlessness can lead to anxiety, and anxiety can increase the breathlessness. So that's a vicious cycle. And another thing is that breathlessness has a complex pathophysiology in COVID-19. Previously, we thought that it might be due to pneumonia, pleural effusion, or things like that. But now the etiology people are talking about are changing. The beta chain of hemoglobin is attacked by the COVID-19, and it causes iron to dissociate from the porphyrin, and this will lead on to reduced exchange of oxygen and carbon dioxide. So we don't know what is the actual pathophysiology of the breathlessness in COVID-19. And the patients, they understand that when they have comorbidities or when they are aged, they know that they are more prone to have more complications, including breathlessness and death. So all this can lead to fear and anxiety, which again lead to breathlessness. So all these things are a vicious cycle. So we have to understand all these things while we manage breathlessness in COVID-19. So how can we manage breathlessness? So we have to definitely follow the COVID-19 management protocol, which is which being done, and there will be many guidelines. So we have to follow that. Then we have to correct the correctable factors, like maybe along with the virus, there may be a secondary infection or things like that. That has to be managed. And bronchospasm should be treated with bronchodilators. Suppose the patient is not having an acute symptom, then non-pharmacological measures would help the patient. Proper positioning, we sometime may tell that okay, patient should be in supine position and lying, or the position which the patient likes or which the patient is comfortable with. should be given to the patient. And relaxation techniques, breathing techniques like pursed lip breathing might help the patient. So in the pursed lip breathing, the patient will be exhaling. Exhaling will be prolonged compared to the inhalation. So exhalation is prolonged, maybe twice as that of inhalation. And we know that directing air with a handheld fan or the face can reduce the feeling of breathlessness. But in COVID-19, we fear that it can produce more aerosols, and that can cause more infection. So it is not advisable to use fan or something like that. So we have to use some clothes which can cool the face. And the pharmacological management, if the patient has mild to moderate breathlessness, we can use morphine. So morphine 2.5 to 5 milligram orally every 4 hourly, or if there is injection, you can give 1 to 2 milligram subcutaneous every 4 hourly. And if the patient is anxious and agitated, then we should be using a benzodiazepine along with morphine. So the all of us, many of you are palliative care physicians, so I need not tell you what is the mechanism of action of morphine. So morphine, it actually carbon dioxide is the reason why it stimulates the respiratory center, and then the respiration increases. So morphine, it reduces the hyperventilatory response to hypercapnia, and it thereby it reduces the respiratory rate, and then it reduces the workload also. It also helps to dilate the pulmonary vasculature, and the ventilation perfusion ratio will also be better. And in addition, morphine sedates the cortical center, so that the feeling of breathlessness is also reduced. If morphine continuous infusion of morphine and midazolam is another option, which can be either by intravenous route or by subcutaneous route. If the patient in ICU, non-pharmacological measures may not be a possible option, but if possible, do it appropriately. And pharmacological management is again with morphine, but patient may not be able to swallow. In such situation, we have to use parenteral morphine by intravenous route or by subcutaneous route. So 1.5 to 2.5 milligram of morphine every 2 hourly, or if morphine is contraindicated, like patient is in renal failure, then fentanyl is advised, and 25 microgram of fentanyl intravenously or subcutaneously every 2 hourly can be given. And we can also use SOS dose of morphine or fentanyl if needed. Then if patient is agitated or anxious without delirium, then we can use benzodiazepines, either midazolam or lorazepam. Lorazepam can be given sublingually, but again there is a fear of more aerosol production. So maybe better to give by intravenous or subcutaneous route. So we can also use continuous infusion, either by syringe pump or by syringe driver. Injection morphine 15 milligram or fentanyl 100 microgram along with midazolam 10 to 30 milligram over 24 hours. So if the patient has significant breathlessness, which usually occurs towards the end of life, and if the respiratory rate is more than 30 per minute, then we can continue to use the same medication, morphine and fentanyl, but the dosage need to be increased. So the morphine will be increased to 2.5 milligram IV or 5 milligram subcutaneously. Fentanyl 25 microgram to 50 microgram, and midazolam also. We have to continue this every 15 to 30 minutes. We have to use this till the patient has proper symptom control. So if we give only one dose and if we leave it there, patient may not have good symptom control. So we have to monitor the patient, and if there is no symptom control, we have to administer again. And this problem can be avoided if you can give continuous infusion. So continuous infusion of morphine with 30 milligram or fentanyl 150 to 300 microgram along with midazolam 15 to 60 milligram over 24 hours. So another problem which occurs, we have seen that in COVID, cough is also one of the common symptoms. And non-pharmacological management is first advised to the patient. Warm saline gargle or increase the fluid intake, using ginger or honey. Those are some non-pharmacological management. And if the patient has dry irritant cough, then there are some medications which can be used like dextromethorphan. Dextromethorphan is available as syrup as well as lozenges. And if it is not controlled with the dextromethorphan, we can move on to the next step, which is morphine. And morphine is used in low doses, 2.5 to 5 milligram for 4 to 6 hourly, depending on the severity. So for the benefit of those who are not working in palliative care, I am talking a little bit about morphine. So morphine is a mu-opioid agonist, and morphine can be administered through various routes. It can be given orally, intravenous, subcutaneous, or parenteral, epidural, and intrathecal. So it can be administered through many routes. And morphine is absorbed if you give orally from the upper small bowel. And after absorption, what happens? It is absorbed into the blood vessel, it goes into the portal vein, and then to liver, where it is metabolized. And the metabolites are liberated into the systemic circulation. And the main metabolites are morphine 6-glucuronide and morphine 3-glucuronide. And morphine 6-glucuronide is the active metabolite which will give pain relief. And morphine is excreted by glomerular filtration. So in renal failure, the metabolites accumulates and it can cause opioid toxicities. So in renal failure, we have to use other opioids which are renally safe, like fentanyl or methadone. These are the two renally safe opioids. So some of the facts which we have to understand about morphine is duration of action is 3 to 4 hours. And peak action, if you give orally, it is within 1 hour. And if you give intravenously, it is 5 to 15 minutes. And the side effects of any opioids includes constipation, which is the most important side effect, and it occurs in almost all patients. So we have to use some stimulant laxatives to reduce the constipation. Nausea and vomiting, if a patient is opioid naive, then in such patients, there's a chance of producing nausea and vomiting. It occurs in almost 30% of patients. And the mechanism of nausea and vomiting is it is due to stimulation of chemoreceptor trigger zone, and it can also produce constipation, which can lead on to nausea and vomiting, and also by stimulating the vestibular apparatus. So for the first 3 days, we have to use some antiemetic, usually metoclopramide or any other dopaminergic antagonists like haloperidol, domperidone, or even 5-HT3 antagonists like ondansetron can be used. But we prefer metoclopramide due to many reasons. And stiffness and tiredness, which can also occur for the first few days, but it is self-limiting. Dry mouth, itching, urinary hesitancy. These are the rare side effects. So when we start morphine in COVID patients, we have to understand that we have to give a laxative, that is stimulant laxative, uh, and maybe metoclopramide first for the first 3 to 5 days. And if the dose of morphine is more, it can also it will cause delirium, myoclonus, and drowsiness. And if there are the signs, that means we have to reduce the dose of morphine. But this is not an indication to stop morphine. This only says us to reduce the dose. So we already discussed this. Fentanyl is the preferred opioid in chronic kidney disease patients. And morphine can be administered by multiple routes. Even if injection is not available, morphine tablets can be administered rectally. The same immediate release tablet, which can be made into a paste by adding 2 drops of water, can be rubbed over the rectal mucosa, and the effect is same. The duration of action is also same. And we have to give stimulant laxative, bisacodyl, 5 milligram, 2 Hs, and antiemetic metoclopramide or haloperidol. Haloperidol would be a better choice if the patient has delirium. So secretions are another important problem. And this may become more of a problem when the patient is towards end of life, actually when the patient is dying. So suction is not usually advised because when you suck the oral mucosa, it can again produce more secretion. So usually suction is not advised. Place the patient in a lateral position, which will help the secretions to drain. And if not responding to this, then maybe anti-secretory agents like glycopyrrolate or hyoscine-butyl bromide can be used. Glycopyrrolate 0.2 to 0.4 milligram every 4 hourly, either by intravenous or by subcutaneous route. Hyoscine-butyl bromide 20 to 40 milligram 4 hourly, intravenous or subcutaneously. And even atropine ophthalmic ointment, atropine eye drops can be used, 1 to 2 drops 4 hourly sublingually. And we have to also understand that by giving this, we may make the secretions more thick. So we have to actually understand what is the stage of the patient and then only use these medications accordingly. So breathlessness is one of the common problem which may occur in COVID patients, which can be managed by correcting the correctable factors and non-pharmacological management. And mainly the pharmacological management is with opioids, with low dose morphine, or if morphine is contraindicated, fentanyl can be used. And it will not produce respiratory depression, which many people are feared about. So delirium and agitation is the next symptom which can occur, and usually this is what happens. Patient is at home, and when the patient becomes positive, the patient is shifted to a corona care center. And there will be a healthcare team who will be examining the patient. Patient may be anxious, and the anxiety may be due to many factors, like patient is away from the family, and he don't know what is going to occur next. Am I going to be on a ventilator, or if my breathlessness is going to get worse? So all this can lead on to more breathlessness. And worsening dyspnea can lead on to hypoxia. which will produce restlessness and anxious. And patient may be oriented also. But later, because of hypoxia, patient may get disoriented. Then the patient may be agitated as well as disoriented. So there are these are two situations. One is agitated and oriented, but another situation is agitated and disoriented. So assessment of delirium, there are many scales used for screening and diagnosing delirium. We know that DSM-5, MMSE, Memorial Delirium Assessment Scale, Confusion Assessment Method. So there are many scales which are used for diagnosing as well as screening delirium. And 480 delirium assessment tool is a simple tool which can be used by anybody to diagnose delirium. So this includes 4 factors. One is alertness, how alert a patient is. And you can also see it can be scored from 0 and 4. Then AMT4, abbreviated mental test, in which you ask about age of the patient, date of birth, name of the hospital, and current year. And then attention is also checked, asking the patient to tell the months of a year, but this is in so the next thing is acute change or fluctuating cause, so which is one of the commonest feature of delirium. And this is then the total score is looked into, and if the score is 4 and above, it is possibly delirium. So we have to use the treatment of delirium. So what is the evidence for management of agitation of delirium in COVID-19 patients? So you can see nice guidelines and German guidelines. CAPC also talk about, that is Center to Advanced Palliative Care, also talk about management of anxiety and delirium in COVID patients. So what are the causes of anxiety or agitation, delirium in COVID-19? This may be due to breathlessness or the simple things which we usually come across in palliative care are urinary retention or constipation, which is missed by many other people. And untreated pain is another common cause of delirium. And withdrawal can occur. We know that many people use alcohol, and now it is not available. Then opioid withdrawal. All these can cause delirium. So the treatment should be directed towards the cause. And management includes both non-pharmacological as well as pharmacological management. Then the healthcare professionals, they are very busy and they are seeing many patients. So they have to keep cool, and they have to start a gentle conversation with the patient. Reassure the patient, because many patients will be very anxious because they are away from their home, they are isolated. So we have to reassure the patient. Keep the room airy and lighted, and ask the patient if they want to convey a message for their family, because they are isolated for some time, maybe at a home or maybe at a hotel, and then they are directly brought to the hospital, and they don't know whether family have knew that I have been in the hospital. So it is important to ask them, and also encourage them to ask questions. They might have many questions, including the cause of breathlessness. Am I going to be alone in a room? Will there be another patient? So there are many questions which they wanted to ask. So the pharmacological management for a patient who is agitated and oriented. So agitation with orientation. So if it is mild, if the patient is able to swallow, then we can give benzodiazepines orally. Lorazepam or clonazepam can be used. Lorazepam can also be given sublingually, 0.5 to 1 milligram BD, or clonazepam 0.25 to 0.5 milligram BD. If the patient is unable to swallow, then we have to give injection 2.5 to 5 milligram of midazolam, either subcutaneously or intravenously. If the patient is having moderate agitation, then we have to use a continuous intravenous or subcutaneous infusion of midazolam. And if the symptoms persist even after the infusion, then it is advisable to add an antipsychotics, and injection haloperidol is the common medication which we use. And the dose can be 0.5 milligram every 15 minutes or 1.5 to 5 milligram in 24 hours. So we were talking about a patient who is agitated as well as oriented. But now we are moving on to a patient who is agitated but disoriented. So we know that if the patient is disoriented, the drug of choice is antipsychotic. So the injection haloperidol, which is the commonly used antipsychotics, can be given intravenously or subcutaneously. And if the patient is able to swallow, of course, orally, 1.5 milligram. And it can be increased up to a dose of 5 milligram. Or a bolus dose of injection haloperidol can be given intravenously or subcutaneously and followed by a continuous infusion of haloperidol. If the patient is having moderate agitation and disoriented, then we already started the patient on haloperidol and the patient is on 5 milligram haloperidol. Now we can add injection midazolam to this. So injection midazolam 1 milligram slow IV or subcutaneous, and repeat every 10 minutes till the patient becomes quiet. Or a bolus dose of injection 2 milligram midazolam can be given intravenously or subcutaneously, and then we can continue with a continuous subcutaneous infusion or intravenous infusion of midazolam and haloperidol. If the patient has intractable agitation and delirium, which may occur if the patient is going to die or towards end of life, we can increase the dose of haloperidol and up to 20 milligram per 24 hour can be given. And we also need to add midazolam up to 30 milligram, which is given as a continuous subcutaneous infusion or continuous intravenous infusion. So in summary, patient who has agitation, we have to find out if they are agitated with confusion or without confusion. And we can assess delirium by using 480 delirium assessment tool. If the patient has pain, we have to treat with either with paracetamol or with opioids. And it is also important to ask about history of withdrawal of medications or substances or any other things. Then if the patient is anxious as well as restless without disorientation, benzodiazepines is the drug of choice. If the patient is disoriented, then antipsychotics should be given. So next is the most common symptom which occurs in COVID is fever. So which drug to be given if the patient has fever? So there are controversies regarding what medication has to be given. This all started with France health minister's tweet regarding ibuprofen, saying that it can aggravate infection, and he told paracetamol is a better option. And many other doctors supported this view, and they say that anti-inflammatory medications like ibuprofen dampens down the immune system, and which can reduce the or slow the recovery process. And they understand that COVID-19 it reduces an enzyme that regulates water and salt concentration in the blood, and that can also lead to pneumonia. And they say that the ibuprofen can aggravate this. Following this, the WHO has come up with this tweet. WHO does not recommend against the use of ibuprofen. And they also said that they are waiting for more evidence regarding this. But the NICE guidelines, they advise to use paracetamol. And fever, which is the most common symptom, which usually occurs 5 days after exposure. And non-pharmacological management, as we know, advise the patient to take oral fluids and not more than 2 liters per day. So paracetamol is the drug which it is advised by many bodies to treat fever in COVID-19. And the dose is 0.5 to 1 milligram every 4 to 6 hourly. And we know that maximum dose is 4 gram per day. And patients with COVID-19 can have arthralgia and myalgia. So in those patients also, paracetamol is the preferred drug over NSAIDs, because NSAIDs can cause many side effects, which we all know, that it can cause gastritis, it can lead to renal failure, it can increase the blood pressure, it can precipitate renal failure. So NSAIDs are not the preferred medication in the treatment of arthralgia or myalgia in case of COVID-19. And we also understand that the patients who are seen by palliative care people are more prone to have COVID-19 because they are immunocompromised. And many of these patients will be on opioids. And the American, these are guidelines by American Society of Regional Anesthesia and European Society of Regional Anesthesia. They advise to continue with the ongoing opioid treatment. So if you see any patients who are taking opioids, it should be continued. And if unless the patient has some other problems, like if the patient has renal failure, then the dose of morphine has to be adjusted. And as we know that the temperature can influence the absorption of transdermal fentanyl patch. So if a patient is on transdermal fentanyl patch, and if the patient has fever, we have to monitor the patient. So we already touched on the side effects of NSAIDs. So the fever and arthralgia or myalgia in patients with COVID-19 has to be treated with paracetamol. And if they have more pain, then opioids would be a better choice than NSAIDs. So thank you. That's about the various common symptoms from a palliative care, how to treat from a palliative care perspective. Thank you. Any comments or questions?
You can either raise your hands or unmute yourself and speak.
Sunil, thank you for a comprehensive presentation. It is very informative. I just had one question. The patient is on buprenorphine patch. You said if they have fever and fentanyl patch, the requirement will increase. What about buprenorphine? Is it similar to fentanyl patch? Can you hear me?
Yes, we can hear you.
Okay.
Moira, would you like to comment on that?
Sure. Greetings, everyone. I think it's a good question. All I'd say is it's a relative increase. So when the initial pharmacokinetics and pharmacodynamics were done for these patches, if you put like a hot pad right on top of them, it certainly increases absorption. Fever also increases absorption, but usually that's still well within the spectrum that's safe. The only time I would have some concerns is if someone was already opiate toxic. So if there was some other reason that was making them opiate toxic, then I would be careful to give a reduced dose in fever. Buprenorphine patches are very low dose. So I think it's more of a theoretical than a practical problem for most people.
Thank you. Thank you, sir.
Anybody else?
Yes.
Hello,
What's
Sunil.
the role of steroids?
Role of steroid in? Hello, madam.
Yeah, there are contradictory views. Some people say you're not supposed to use it, and the new publications say you are supposed to use it early in the disease, which will give you better prognosis.
Okay. So I don't think I am competent enough to answer that question. Are there anybody in this group who treat patients with COVID-19?
In the absence of anyone else, I'm not treating them actively, but I am looking at the research.
Yeah.
And I think, Geeta, you're right. But I think the crucial thing is some of those decisions will be made by the admitting critical care teams. There is a role, I think, in the inflammatory process with a viral pneumonia. But I don't think there's any role in a kind of prophylactic use of them. So I think this is part and parcel of an acute disease management, which would need an assessment of the viral pneumonia. And we should be careful of overusing them in a non-acute setting, I think is the message.
Thank you. Thank you.
Sonia, there is a chat question also about the ibuprofen. Do you want to clarify?
Can you repeat the problem with NSAIDs in COVID? So, okay, this is not solid evidence because there are both viewpoints regarding ibuprofen. So, what they say is that any anti-inflammatory can dampen down the immuno mechanism, and that can delay the recovery from the infection. That is one. That is what they talk about. It is, but WHO has said that there is no evidence to talk about this regarding whether to not to use ibuprofen. So we are not sure what is happening. Maybe after some time we will have more evidence on this.
Sunil, I would just back you up on that and say that actually some of the initial stuff was fake news coming out of an Austrian site. I think the WHO has been clear that there's no evidence. The British government has said, if you've got an option, use paracetamol, but it's not contraindicated. So I think we're just using paracetamol as our antipyretic of choice, but we're not contraindicating fully.
Yeah, and we also know that NSAIDs have many side effects, so which we should be careful. So paracetamol is a preferred medicine to treat pain or fever in COVID-19.
Dr. Anshika?
Thank you, Dr. Sunil. It was a very nice presentation. I wanted to ask your latest analysis of hydrochloroquine and azithromycin. Many published articles may be there. So what is the take on that right now?
Moira, do you have anything to say?
Yeah, there are a number of trials taking place. I think everybody at the moment is saying the evidence is not clear enough to use it as routine prophylaxis. It does cause significant problems, as you know. People in India know about hydroxychloroquine. There already has been episodes, even in India, of children, one child who may have died of renal failure because the family read the news and put them on hydroxychloroquine. I think the best option there is just like the steroid issue, use the protocols by the treating hospital, and the government, I think, are doing a good job at getting those protocols out. And if there are options to enter people into these multi-center trials, I don't know if they're running in India, then we should do that. But hydroxychloroquine certainly seems to have a place, but it has a lot of problems. So it has to be used with care and as part of an overall treatment protocol, not as a broad prophylaxis.
So I know that in Kerala guideline, hydroxychloroquine is used to treat patients, and prophylactic use is advised in healthcare professionals who treat COVID patients, and also for the close contacts of the family members of COVID positive patients. That's what the guidelines is. And as Moira told, there are I recently 1 or 2 days back I read that somebody is doing multi-center trial on hydroxychloroquine.
Dr. Mohammed?
Hi, I'm Dr. Mohammed. My question is, what is the role of vitamin in preventive measures? Is there any working?
Sir, the question wasn't clear. Can you repeat it once again?
So what is the role of vitamin C as a immune boosters in the role of the preventive measures?
It is. I think it is not given in any guidelines, but the people are advocating for vitamin C. But I'm not sure if anybody. Yes, Myra, that's what he was asking. Vitamin C. Can you unmute yourself?
Yeah, it's a good question. It's being talked about everywhere. There's absolutely no evidence for high dose vitamin C specifically for COVID. I think there is, of course, the general evidence that a diet which is good in vitamin C and fresh food and so on is a good idea in general. But I don't think there is any evidence at all that high dose vitamin C has any effect on COVID per se.
There is a talk about the vitamin D. It's very useful, especially it is given in the loss of 60,000 units per week, especially in COVID patients. Have you got any idea?
Role of vitamin D.
Is it vitamin C
Yes,
or vitamin D?
Vitamin D.
No, people are talking about vitamin C as well as vitamin D.
Okay, thank you.
Any idea? Anybody? About vitamin D? Yes, Moira.
I was just going to say, feel free to share any of those papers with us. We can look at them. But again, my reading of the evidence that is obviously people are trying different things, but I don't think there's a complete evidence for vitamin D either.
Sunil, just one observation.
Yes, madam.
Because we are talking to opioid, non-palliative doctors. I think it would be nice to tell them about the toxic effects of morphine, just like you mentioned about the adverse effects.
Okay, side effects and toxic effects are different. We talked about the side effect of opioids in general, like constipation, which is the most common side effect. Then nausea and vomiting, which occurs in opioid patients for the first few days, 3 to 5 days at the maximum. Then sleepiness and tiredness for the first few days. These are the most common side effects. Side effects means these are adverse effects with normal therapeutic doses. And toxic effects means these are the adverse effects when you take more than the required dose of opioids. So the signs and symptoms of toxic effect is delirium, myoclonus, and extreme drowsiness. So if the patient has these symptoms, you have to reduce the dose of opioid. You do not stop the medication, you have to reduce the dose of opioid. And maybe symptomatic treatment may also need if the patient has severe delirium. Okay, any more questions?
There's one on the chat, Sunil.
If patients have.
If the patient has pain, can we escalate the dose of morphine? Yes, Kabindra, as we know, we can increase the dose of morphine by maybe 30 to 50%. What about diarrhea in COVID-19 patients? We know that diarrhea occurs in some patients, but I don't know what should be the treatment for diarrhea, but of course, we have to keep an eye on the fluid balance. I think it is more of symptomatic treatment. There is another question. How do you distinguish agitation, delirium from morphine toxicity that is and that due to COVID per se? Okay, so I think we have to get some history from somebody. If the patient is not in delirium, from the patient itself or from the family members. We can ask the family members, was he okay before he reached here? Have he had any myoclonus or sleepiness, which usually occurs along with morphine toxicity. So I think that can give us a clue whether it is morphine toxicity or if it is due to COVID. Yeah, the slides will be shared. But we have to also understand that COVID sometimes can cause renal failure, which can also cause opioid toxicity. Yes, Myra.
I was just going to just emphasize, you did it very nicely, but just to re-emphasize that what we're hearing from colleagues who've looked after many patients with COVID rapidly progressive pneumonia is this agitation, breathlessness complex, which is actually very rapid and very clear. So I think most of the time we just need to be ready to manage that new, very severe breathlessness agitation complex with the excellent guidelines you've given. And of course, as usual, for other settings, use all those skills that we've been describing. But the new skill is this particular severe breathlessness and anxiety agitation complex. And Sunil, that's what you described now.
And also in COVID patients who are rapidly progressing downhill, they will be also monitoring the blood gases of the patient, right? So because if the patient is hypoxic also, he can get confused and agitated. So if that is normal, then it may not be so much due to COVID. Or, I mean, it may not be because of hypoxia at least. If there's hypoxia, then that has to be corrected.
Okay, thank you, madam. Any more questions or comments?
Sunil, do you want to mention the ebook as well that people can have access to?
So PalliCovid group has come up with an ebook which we will be sending to all of you. So which contains guidelines, algorithms on symptom management and psychosocial interventions and self-care, when burnout, etc. So we will be sending that. Rajshri madam, do you have any comments?
No, Sunil, nothing specific. Am I audible?
Yes, yes.
Okay. Because connectivity is poor, so I was in doubt that whether what I have answered was heard or not. Okay.
Dr. Mohammed, were you joined for the first session or can you unmute yourself?
Okay. Actually, I got the password and user ID today only. That is why.
Okay, where are you working?
Right now, I am in a Qatar. Just come before 1 month. Hello.
Okay.
I was there in Calicut Institute of Palliative Medicine.
Okay.
Thank you.
If there are no more questions, I think or comments, we can wind up this session. So the important points which we discussed are the common symptoms are cough, breathlessness, fever, myalgia, and agitation and delirium. If the patient is breathless, we have to correct the correctables and treat bronchospasm if present. And then we have to give symptomatic treatment if the patient is not improving. The symptomatic treatment is with a low dose morphine. And if morphine is contraindicated, fentanyl can be used. Morphine can be used both, it can be used through many routes, but or the tablets can be used either orally or rectally, and low dose injection can also be used. The treatment of cough depends on the etiology of the cough. Then the non-pharmacological management like warm saline gargle using ginger or honey can relieve the symptoms. If there are no relief, then pharmacological management can be tried. Dextromethorphan, which is usually available as syrup or lozenges, can be used, or if no relief, then we can move on to morphine, low dose. Then agitation can be with orientation or without orientation. Agitation with orientation can be treated by benzodiazepines, and agitation without orientation, then we have to use antipsychotics as the first choice of medication. Then fever is usually treated with paracetamol, and pain, myalgia or the arthralgia can be used treated with paracetamol again. If the patient is already on opioids, then there is a chance that they may not have taken the opioid along with them, and withdrawal can occur. Not only in case of opioid, but also with alcohol or any other substances. So we have to find out this and treat accordingly. So thank you all for very interactive session.
So I've shared the feedback link. Give it a minute, do it, then only leave the meeting. So we can meet you tomorrow with a session on principles of communication to provide emotional support at this time, taken by Dr. Biju Raghavan. Thank you all for joining in. See you tomorrow.